Everybody, my name is Erin Healy. I'm a fourth-year resident in radiation oncology at Ohio State, and I'd like to thank Dr. Rath and Dr. Abhishek for inviting me here today, and the committee, the organizing committee. In the next 15 minutes, I'm going to attempt to cover adjuvant therapy for salivary gland tumors, and I'll try to stay focused on the adjuvant therapy for the sake of time. I have no disclosures. This is a brief outline of my talk. I'd like to first outline some epidemiology, then I'll talk about anatomy, histology and why that's important, an overview of the treatment for salivary gland tumors, and then indications for radiation. And I'll go into some radiation techniques, and I'll address the role, or attempt to address the role of chemotherapy, and then some ongoing clinical trials. Similar to sinonasal tumors, the salivary gland tumors are actually also very uncommon. They represent less than 1% of all cancers in the U.S. There's about one case per 100,000 in the U.S., which represents about 3 to 6% of all head and neck cancers, similar to sinonasal. The median age for malignancy is 55 to 65, whereas the median age for a benign pathology of the salivary gland is 10 years younger. And the parotid is the most common site. Here's just kind of a picture of the major salivary glands. There's the parotid gland, the submandibular, and the sublingual. The most common site of any neoplasm is actually the parotid gland, as I mentioned before, but only 25% are actually found to be malignant. Another thing I'd like to mention is that there are also minor salivary glands that line the upper aerodigestive tract. Histology is very important in salivary gland tumors. Particularly, the first division is benign versus malignant. As you can see here, similar to sinonasal tumors, the WHO histological classification is enormous. There's about 17. You can't even read them up there. There's so many of them. But there's about 17 different types of malignant tumors, and there's also a few benign tumors. And 75% of the tumors are typically benign, but 25 are malignant. And these are the malignant ones. They're very heterogeneous. And we like to focus on the two most common, which are the mucoepidermoid, which represent about a third, and then the adenoid cystic, which is about 22%. And I'd like to also highlight this because for malignant histologies, the grade is what's important because that is what predicts lymph node involvement. So once you've decided benign versus malignant, you look at grade. As you can see here, mucoepidermoid, there's high grade, and adenoid cystic is typically high grade, but there's also mucoepidermoid here in the low grade, which is important. This is a basic NCCN guidelines for the treatment of salivary gland tumors. As you can see here, that surgery is I'm not going to go into surgical details. I'm a radiation oncology resident, but basically, you can see here that surgical resection, when possible, is the mainstay of treatment. And even when a tumor is resected, if it recurs, surgery remains the mainstay of treatment. But when after surgery, if there are certain features, as you can see here, I'll go into these in more detail later, but basically, adenoid cystic and some adverse features will predict for adjuvant radiation and consideration of systemic therapy. And as you can see down in the lower half, down in the bottom corner here, if no further surgical resection is possible, then they consider definitive radiation or systemic therapy with radiation. So these are my indications for adjuvant radiation. We will say underneath the high-grade adenoid cystic histology, any unresectable microscopic or macroscopic residual disease. Any disease that recurs and recurs and recurs is also considered for adjuvant radiation. Typically, T3 and T4 disease that has gone out of the parotid gland is an indication. And then even for low-grade tumors, if you have a low-grade tumor and you have any of the adverse features, aside from grade, like or positive margins, close margins, perineural invasion, lymph node metastases, or lymphovascular invasion, those are actually also indications for adjuvant radiation. This was discussed in the workshop a few days ago, but for postoperative radiation, You typically want to do this within 6 weeks of surgery. We typically only cover the unilateral neck, levels 1 to 3. We cover, if it's lymph node positive, we typically go down to level 4, at least at our institution. And if there's perineural invasion for adenocystics, we actually cover all the way to the skull base. We use IMRT or 3D conformal, and we typically use photons. The doses have already kind of been over, but for the high risk regions will receive 60 to 66 gray. Intermediate will be 54 to 63, and the low risk will be 44 to 50. For definitivation or with gross residual disease, we use, again, IMRT or 3D conformal and photons, but our doses are higher. And this is a picture right here. It's actually the 90% isodose line, just showing how conformal we can get with photons. But what about protons? Some people will say that IMRT, I think it was already mentioned before, you have a low dose bath that will actually hit the opposite parotid, which is what you don't want to do to someone who has one parotid removed. So people have considered protons, just so you can avoid the exit dose. And this is a study that was done in Mass General here with 23 patients. And they had, I think they're all adenoid cystic with skull base involvement. And they actually showed, if you see here, the 5-year local control is 93%, and overall survival is good. This is just a comparison of the proton plan versus the IMRT plan. As you can see here, this low dose bath right here is touching the opposite or the contralateral parotid. And here we actually get parotid sparing with protons. But again, protons have their own limitations and availabilities. Anyone that's talking about salivary glands will talk about this trial, which is the only randomized trial in salivary glands, and looking at neutrons. And as you can see here, photons versus neutrons, local control, this is local failure rate over here, was significantly less than it was with photons. And this is for unresectable, by the way. And as you see here, overall survival, however, was not shown to be significant. But neutrons also have their own limitations. They're limited. I think they're only available in Washington State. And they're not highly conformal, and they're difficult to modulate. They also found with this trial that toxicity was significantly higher. And I don't know how many people here use carbons, but carbons are actually emerging. I don't have a slide on it, but carbon therapy is actually emerging as another alternative for unresectable salivary glands. And the next question is there a role for chemotherapy? And right now, a lot of the data that we have in salivary gland is based on small retrospective studies with various different types of chemotherapies, various different types of histologies. There's no real strong indication for it, and there's not a lot of data to base our decisions on. What we have going on in the United States right now is a clinical trial with RTOG, it's 1008, looking at resected high-risk malignant salivary glands, adjuvant concurrent radiation chemotherapy versus radiation alone. As you can see here, let's clear. Sorry. As you can see here, it's intermediate grade, high grade salivary gland tumors. They're randomized to radiation plus cisplatin versus radiation alone. So for our patients that are coming in that fit this criteria, this is what we are enrolling on. And that's the end of my talk. Thank you very much. I'd like to thank Dr. Chakravarty for sending me here, and thank you all for having me. It was a great time.